In other activities such as cooking and cleaning in the house, she started taking time doing them as she became more meticulous. She makes sure that the vegetables were cut at a particular length and width, and otherwise she would feel uneasy. Her family started to notice that she would take too long to prepare the ingredients and that she was becoming more careful that everything is cooked and everything is clean. She would wipe and rewipe the kitchen counter to make sure that it is clean. And she developed a tendency to look back multiple times to check if the stove was really turned off. Even hours after, she would find herself checking if she really turned it off and goes back to the stove to make sure the valves are closed, which would relieve her anxiety. 10 months prior to consult, her unwanted thoughts escalated to thoughts that seemed irrational to her, but she just can't seem to ignore. Her thoughts included questions of if she harassed someone before, or did she do something stupid with someone, or if she hurt someone, or did someone die because she did not do something right, or what if her words or actions would cause someone to kill themselves, or is it possible that she's pregnant, or what if she become a teenage mother or a homosexual, or did she send nudes to someone? When Shane experiences these thoughts, she would become nervous and have cold hands and feet and lightheadedness. To ease her anxiety, she would repeatedly think over the things she said or they did, and again would replay all the conversations in her mind and repeatedly apologize as well. If she fears that she has committed a mistake, she would send lengthy texts to her friends or classmates and apologize for fear that she might have offended them. In fear that she might hurt others, she also refrained from touching knives and she would repeatedly ask her cousin if she had hurt anybody. In the interim, Shane also started having trouble with her modules. She is preoccupied that she has to make things perfect in her modules. She started rewriting her modules multiple times, even for small mistakes like an erasure, or if she feels that her written work is just not right. She would spend hours on one single module, resulting to backlogs that alarmed her teachers. Despite noticing her piling up undone modules, she feels compelled to recheck and rewrite her modules even for minor mistakes. At times, she would rewrite her modules simply because she thinks she had written in a wrong stroke or that she feels compelled to rewrite them. She also became obsessed with not being able to fully grasp her reading uh, assignments, fearing that she must have missed something, and would then reread and reread the materials multiple times. Soon she became frustrated of her inability to pass her modules in time, and she was reprimanded by her teachers and her family about not passing her modules, and she felt she was a failure and she became disappointed of herself. 3 months prior to consultation, Shane felt she wasn't doing anything right anymore. She would be anxious over unwanted thoughts and would waste her time, quote unquote, thinking about them, spending more time with her thoughts and then more than her modules. She came to dread making her homework, and around this time, Shane developed a depressed mood. While she enjoyed doing schoolwork and reading, it no longer interested her. She blames herself for her poor performance and felt helpless. She felt tired. Pagod na ako mag-isip, pero kung di ko siya isipin, hindi rin ako malilive. She lost concentration on her schoolwork, leading to poorer performance tests. Shane admitted to wishing she just died, but denied any intention to harm herself. In the interim, Shane continued to have depressed mood, loss of interest, and she blamed herself for her situation. She lacked the energy to do her homework and lost concentration when she attempts to do so. Although she lacked appetite, she would force herself to eat during the mealtime, and she also started having problems with initiating sleep. Shane denied having had elevated mood or irritable mood associated with increase in energy, grandiosity, indiscretion, decreased need for sleep, increase in activity, flight of ideas, or talkativeness. 1 month prior to consultation, the above symptoms continued, and her teachers became worried about her declining performance and notified her uncle. In an attempt to help her, her uncle finished some of her modules so she could meet the deadlines. Upon seeing their work, however, she was not satisfied and tore her modules. Frustrated at her incapacity to finish her modules and seeing that her family thinks she is failing school because of her desire for perfection, she felt more down and she blamed herself that if not for her wasting her time being thinking and rethinking things on her head, then she would have been able to finish her modules and pass in time. Her uncle, mother, and grandmother would tell her to just pass and would verbalize their exasperation at her missing deadlines, making her feel worse. The continued decline in school performance prompted her uncle to bring her to IPBM for consult. So again, for the pertinent negative, Shane denied any episode of irritable or elevated mood with hypomanic or hypomanic symptoms and no noticeable tics or involuntary muscle movements as well. So for the past psychiatric and medical illnesses, these are unremarkable. However, family history is remarkable for generalized anxiety disorder, MDD, and substance use, as well as hypertension. So this is a genogram. Of particular note, um, there are three uncles in the maternal side of Shay, wherein one is a diagnosed case of schizophrenia disorder. This patient is seen in our institution, and this patient is on olanzapine. And another uncle diagnosed with generalized anxiety disorder. This patient is also seen in our institution and is maintained on escitalopram. Then we have the uncle who had depressive symptoms and substance use disorder. However, for this patient, there was no record, although they said he had consult here years before. We don't have any data with paternal side, however, because they have been separated early on, as we will be discussing in the anamnesis, and also with the grandfather as well. We have no data because of they also separated. Uh, the grandmother and grandfather also separated at an early time. So Shane was born to an affair between her mother and her father and mother. Her father was married with three children from his wife, while Shane's mother was his mistress. Their relationship was a secret until Shane was born. Her father left her and her mother when she was 2 years old, and to earn money for her child, Shane's mother left work as a domestic helper in China on the same year, and Shane was cared of by her grandmother. Over the years, she has grown apart from her mother, except for their brief contacts when her mother goes home once in 1 to 2 years. On the other hand, she does not know much about her father, and she was informed her father died of diabetic complications when she was 10 years old. She had sought contact with her half siblings, but they have blocked her in social media, and she was not able to talk to them. Shane's relationship with her mother is strained, and she feels distant towards her mother. Since in the past 5 years, the relationship consists of irregular video calls to check on each other. And Shane does not tell her mother her problems. She feels disappointed towards her. And especially when her mother chose not to go home to Davao and instead stayed in Manila. Shane is close to her grandmother, whom she describes as caring and loving. Her grandmother took care of her since she was 2 years old, and she is disciplined by verbal reprimand and more likely described to be permissive in parenting. It is to her grandmother that she is very close to and whom she can tell about her problems. However, due to the death of her uncle, her grandmother was withdrawn emotionally and was not available for Shane when she needed comforting. Shane lives with her maternal uncles and cousins, and although they live in the same house, she describes the relationship as casual. Although they do get along with each other, she cannot identify an uncle whom she is close to and whom she can confide her problems with. Despite having many people in the household, Shane feels isolated from them. So Shane is the product of an unplanned and unwanted pregnancy. Her mother was his father's mistress, and when Shane's mother learned about her pregnancy, she manifested symptoms of depression. She was persistently sad with associated decreased sleep and appetite, and she withdrew from her family and friends and isolated herself in her room. Her family suspected that she attempted to end her pregnancy using an abortifacient, but this was not confirmed. Shane's mother likewise denied this. And Shane was born full term by a normal spontaneous delivery at a local hospital, and there was no known complications during labor and delivery. Shane was immediately bottle fed after she was born, with complementary feeding given at around 7 months. Her mother would leave her to the care of her grandmother most of the time, and her grandmother stood as her primary caregiver when she was a child. Her uncle reported no problems in taking care of Shane and described her as, as similar to other children her age. Shane developed at par with her peers. Although it was not formal, she was toilet trained at the age of 3 to 4 years old, wherein she must relieve in a makeshift potty and would be reminded verbally whenever she soils her undergarments. By the age of 4 years old, she was able to go to the comfort room alone, but still needs assistance when cleaning up. Her developmental milestones were reportedly at par with her age, and she did not have any instances of thumb sucking, temper tantrums, head bumping, and other conduct problems. She grew up shy and slow to warm up as a child, and she was close to her grandmother and cried whenever she left. Shane began going to school at 5 years old. She performed well in her academics and participated in school activities. She has only a few close friends and prefers to keep it that way. And although she gets along well with her friends and whom she plays with and studies with during break time. At a young age, Shane's mother would nag her about performing her best at school and would always tell her that she can only depend on herself. She recalls her mother saying not to trust anybody and she only has her own self to rely on. In her mother's words, huwag kang magtiwala sa iba. Sarili mo lang ang pagkatiwalaan mo at kakapitan. Shane recalls feeling accepted and loved by her mother when she receives good grades in school, motivating her to do her best. Shane was very serious about her studies and was described as a perfectionist, which caused her classmates to bully her, which eventually led to her transfer to a different school, as mentioned in the HPI. At home, Shane helped around with household chores such as cleaning the house and washing the dishes. Shane's father passed away when she was 10 years old, and she felt sad that she was not able to get to know him or bond with him. And at that time, she felt both angry and sadness. She was angry that her father and mother were neglectful of her. And on the other hand, Shane was also sad because she felt unwanted and unloved. In contrast to how she felt at home, Shane enjoyed going to school and she continued to perform well in her academics and hung out with her classmates. She finds joy and pride in her academic performance, and she feels happy and proud whenever her classmates and teachers would compliment her on her achievements. And she felt accepted and treasured. She thought that if she continues to do well in school, her mother would also do the same. So, when her father died, she felt the loss and the potential relationship if they had met or have they bonded. So she turned to her grandmother for comfort, and her grandmother would cuddle her when she feels bad about her parents and offer her advices whenever she needed them. When Shane was 12 years old, she experienced being bullied at school, as mentioned, and she also learned that her friends would talk behind her back, and this validated her feeling that she only has uh, herself to rely on. So she withdrew from her friends then and got only two close friends, and she does not trust being with her friends, being friends with others because she is afraid that she will be betrayed at school. Shane is liked by her teachers because of being her dependable and hardworking. She's often assigned as a class leader and keeps order in their class. So again, she's quiet and reserved with a few close friends, as mentioned. Shane belongs to the Roman Catholic faith, and she and her grandmother were previously active in church. However, after the death of her uncle and during the start of the pandemic, Shane and her grandmother no longer frequented the church, and Shane firmly believes in the teachings of the faith and its commandments. She regularly prays at night to ask for forgiveness and does not sleep without doing so as part of a routine. In the past month, however, her grandmother noticed that Shane became less enthusiastic about religion, which gave her the impression that Shane has given up on God also. Shane says that she is still devoted to the religion as praying helps her with anxiety, but lately she feels that she is forsaken because of her persistent intrusive thoughts and failures in school. And both her mother and grandmother encourages her to continue praying and offer her troubles to God. Legal and military history for this patient is unremarkable, and Shane aspires to become a successful professional, particularly a medical technologist or a doctor. And she dreams of being able to help out her family one day. Her menarche started at 12 years of age with a regular 20 to 30 day cycle, 4 to 5 days duration with no dysmenorrhea. She identifies as female attracted to males with no current romantic relationships, but she admits to having several male crushes. The substance and non-substance use history for this patient is otherwise unremarkable. Before I proceed to the mental status examination, do you have questions po, Doc?
Yes. Some clarifications, Noel.
Yes po, Doc.
In your pre-morbid history, you mentioned that she was already a perfectionist, tendency to check and recheck her work, right? Was there a change between the things that she would worry about uh, even before and compared to 36 months prior to consultation?
Um, with regards to her being perfectionist po, Doc, na pre-morbid, it's more on her academics po, Doc. That she would really make sure that she would be able to answer her best, na she's very particular that she had to be perfect in her scores po, Doc. She was even described by her grandmother nga kanang muhilak jud, Doc, kung naay mga mistakes. With regards sa, however, this aside from this 36 months prior, she would also be concerned na had offended someone. She was ano kanang, did she say something wrong? And this was already coupled, Doc, with checking if she replaying conversations in her mind, checking her messages.
And this was not present before
Dili, Doc.
36 months. Okay.
One particular, Doc, na that striked her was na she had this ano, Doc, na fear nga that she sent nude photos to her classmates, which was, she knew that this was unreasonable because uh, it's impossible that she did that, Doc, ba, but she would be compelled to check all her messages in her chat box. Magana, Doc. So murag naging unreasonable na, Doc, ang thoughts niya, Doc.
Okay. So aside from the severity of the symptoms and how it affected her functioning, the content also, tama
Yes.
ba?
Yes po.
Changed. Okay. Sige, sige. I also have another question with regards to the um anamnesis, but for the other consultants, do you have a question pa sa HPI so that we can tackle it as one?
None for me.
Okay. So, since yung question ko, Nwe, with regards naman sa anamnesis mo, can you describe yung bullying ng classmate and or kasi I want to differentiate in my mind if it is also partly just her perception that she is being bullied. Kasi 'di ba, she might be taking non-malicious comments, non-malicious teasings as bullying. So, were you able to elaborate on that?
Actually,
Okay.
Doc, the grandmother really witnessed, Doc, kanang ng sa kanila siya, Doc, the grandmother really witnessed nga they would really shout at her po, Doc, calling her nga kanang kay murag perfectionist man jud siya na kwan murag daw ano jud nila siya, Doc, mga they really call it out, Doc, nga they are really annoyed with her attitude po, Doc.
Okay, okay. Sige, no? Kasi I wanted to clarify that kasi 'di ba, her perception might also be affected, no, of how she takes comments and criticisms.
Yes
So
po.
I was wondering on that if you were able to ask that. Okay.
I was able to include po, sorry, Doc, aside
Ah.
from they were the classmates being irritated sa being perfectionist ng dumurag ni ano po, Doc, na they also touch nga kay perfect daw siya ng attitude niya, daw perfect jud daw pud ang skin nga daw puti-puti jud daw They were, I don't know how they come up to that, but they would also bully that dog, and they would, that's one of the content ng isang bullying nila dog, and the grandmother witnessed also that.
Oh, okay. Okay. Also, can you describe a little bit more for us? Kasi you mentioned na she does not have a very good relationship with her mother, no?
Yes po,
Tama
Doc.
ba?
The grandmother po, Doc, ang would come home 1 to 2 years po, Doc. But there are times nga 4 years, 5 years, dili siya makaano daw, Doc. And they would do video calls po, Doc. But ang tendencies ng patient, since she does not really like her mother, Doc, she would just nga, I need this for the schoolwork. This is the update in my schoolwork. And then the mother would actually try po also, Doc, to reach
But
out.
even before that, can you like when she was younger, you mentioned kasi that it was her mother who instilled don't trust other people, just towards yourself, and you have to be this good at school, etc., no?
Yes, Doc. That's uh, she describes her mother as nagger, Doc. She expects nothing less also from the patient, Doc.
Mm-mm.
She
What
wants
would she say kapag na-disappoint siya?
um nagkanag jud daw ang mother, Doc, nga you could have done better, nga you should do this and that, and I don't know
Uh,
how she connects kay murag ang statement niya na kay you only have yourself to trust, murag ana.
yeah. Okay. Hindi, kasi I wanted to clarify, like, when she feels disappointed towards the patient, does she reject the patient? Does she humiliate the patient? Ano yung,
Um,
um,
so
oo.
I get your point, Doc. I think it's more of the attention po, Doc. The Shane said nga kanang the mother would compliment her, Doc, with if she has yung kanang achievements at school, and she doesn't really get that, Doc, if she doesn't get a perfect score or she performed less.
So, there's this sense na she will only be accepted if she is perfect? Ganun ba?
Yes, Doc, or she did very well po, Doc.
Okay. If she doesn't, paano mag-react si mother?
No attention po, Doc. Wala siyang
As
attention.
in being
The,
rejected?
the, the grandmother would also, Doc, would say nga, that's okay nga, okay lang, ana. But ang perception ng patient, Doc, is she's not well received, Doc.
Okay. But, so does she crave the approval of her mother more than her grandmother?
Yes, Doc. Sa later on sa amo ang session, so she was really hoping that her mother would have a bigger role sa iyaha, Doc, pa. The mother would pay more attention, and this was heightened the time when her father died, Doc, na she realized nga why does her parents
Okay.
does not give that much attention to her, Doc.
How does she internalize it when her mother withdraws the attention when she does not do well?
Um, for her, she's used to it already, though, and
But
she's
what does she think
parang
of
murag
it?
anak man jud na siya ng she's already dumurag do na fix niya na dok ba sa iya nga mind na the mother does not really give attention unless she would able to perform.
Okay. So, but how does she feel about it? Like, does she think na she is not worthy of attention if she is not good enough?
Yes, no.
Okay, sige.
That also extends to her teachers.
Oh,
Nga,
okay.
and
Sige. Okay, I'm asking that kasi later on, I want to see that also in when you're doing your psychotherapy, ha?
yes, ma'am.
What you want to address also, no, in the patient.
Yes.
Sige, thank you, Nev. That's all for me.
Okay. Moving on to the mental status examination. Um, came in well groomed with shoulder length straight black hair, and he wore a blue jacket over a clean shirt and maong pants with face mask and face shield. She had clean, short nails, and she sat on the edge of the chair, leaning forward. Seeing some pencils disarranged in the table, she took the time to arrange them. And she was calm and cooperative throughout the interview. When asked to elaborate on things, she would make motions with her hands as if to emphasize a point. Shane had an anxious mood with appropriate affect, and later on she said she had depressed mood as well and showed appropriate affect when she said it. She had good attention during the interview. She had spontaneous speech and denied perceptual disturbances. She had linear, goal-directed thought process, and she was preoccupied with the unwanted thoughts that came to her mind. Yet she feels the need to think and rethink things to counter these thoughts. Concerned about her modules as well and her backlogs, and she feels that she cannot accomplish her schoolwork and feels ashamed about it. She admits to having passive suicidal ideations, saying mabuti pa siguro mamatay para matapos na, nakapagod na. And she, however, denied active plans for suicide. Uh, she had mixed insomnia, had decreased appetite. Allegedly, there was a decrease in weight, according to the uncle. And she was more active during daytime with decreased libido. She was oriented to three spheres and she had intact memory. She was able to do serial subtraction, but with delays in between. And she was able to spell world forwards and backwards. She was able to abstract and able to discern similarities between a jeepney and an airplane and able to interpret a proverb. She had good fund of knowledge and she had unimpaired judgment and partial insight towards her illness. Psychiatric rating scales at this time were also taken. We have children's Yale Brown Obsessive Compulsive Scale, which revealed a score of 31, which was severe, and PHQ 9 of 22, which also severe. At this point, I'd like to just have a few points on CY box po. So CY box is a clinician-rated semi-structured instrument that is downward age extension of the adult version, which is the Yale Brown Obsessive Compulsive Scale, and it contains the 10 items that would assess the obsession and compulsion severity over the previous week in a Likert scale. And this is administered by the clinician to the youth and parent, either jointly or separately, based on the clinician's judgment as well. So they have this, I don't know, Likert scale, which would assess the interference, the distress, and resistance, as well as the degree of control. So they have a range of severity for both obsessions and compulsions. And the CY box cutoff score used to diagnose mild OCD, which be greater than 8, has a sensitivity of 100%, and the cutoff score of 12 will still yield a 95% sensitivity. Wasn't able to find the specificity for CY box specifically, but for Y box, this is 86%. So uh, this patient was able to check the following in the symptom checklist. So for the physical examination, the patient had stable vital signs, and her anthropometric, she had a BMI within normal range. The physical examination was otherwise unremarkable. Particularly, there was no neck masses to be noted for. The examination of the heart, abdomen, and the extremities was otherwise unremarkable, and as well as the neurological examination for this patient. We have the summary of findings. So we have this patient who have obsessive and compulsive symptoms with concurrent depressive symptoms as well, and the anamnesis with which particular for a negative home environment, neglect and abandonment from the parents, bullying from the classmates, and withdrawal of support initially from the grandmother. And we also have particularly the positive psychiatric illnesses, depression, anxiety, and schizophrenia from the other family members and the other findings. So this is was my initial impression for this patient. obsessive compulsive disorder, and with major depressive disorder. So for my differential diagnosis, these are the following. So I entertained the the diagnosis of generalized anxiety disorder. So this diagnosis was considered because of the recurrent thoughts, avoidant behaviors, and requests for reassurance. However, in that recurrent thoughts are usually about real life concerns. Whereas in OCD, there it would involve content that is odd, irrational, even magical in nature, and also associated with compulsions. Also, in terms of avoidant behavior, the fear is circumscribed for God and does not involve rituals. And the request for reassurance would be focused more in reducing the fear. However, for this patient, the anxiety and worry was due to the intrusive thoughts that was out of control and compulsions to relieve the anxiety, which was better explained by another mental disorder. So GED was ruled out. I also entertained psychotic disorders such as delusional and schizophrenia disorder. So this was because of the fixation of the thoughts. Now we also have to rule out a delusional disorder. However, the patient had insight about her odd beliefs, about her odd thoughts, and moreover, the obsessions were accompanied by compulsions that are not characteristic of this disorder. So I ruled this out. Um, Also, I considered schizophrenia disorder. So this disorder was considered because of the family history and the negative family environment with which Shane grew up. So for the family history, it actually confers a risk of more than 10.9 of at least 10.9%. Also, OCD and schizophrenia can be comorbid in 12% of cases. I also found journals wherein they found at least 2.3 to 2.7% of patients who were diagnosed with schizophrenia disorder with OCD as a prior diagnosis, more like of a prodrome to schizophrenia. So for this patient, however, and also both schizophrenia and OCD would start during some would more often start in adolescence and early adulthood. So also in Meyer in 2014, the study said that the diagnosis of OCD also confers the increased risk of developing schizophrenia and disorder by 5 times. So however, for this patient, there were no criteria on A symptoms. So for this patient, I ruled this out, but I tend to monitor um, for this particular disorder as well. So I consider obsessive compulsive disorder since Shane presented with obsessions and compulsions that are time consuming and results to significant distress and impairment in functioning. So OCD is common in children and adolescents with a lifetime prevalence of 2 to 4% with a mean age of onset of 19.5 years old. And one-fourth of these start at 14 years old. Although there are higher rates of sexual and religious obsession and harm obsession in adolescents as compared to adults, which we see from Shane's history. So per DSM-5 criteria, Shane has recurrent and persistent thoughts with attempts to ignore and suppress these thoughts as well. And she also had compulsions, which were repetitive behaviors and mental acts, which were aimed at preventing or reducing the anxiety or distress. These obsessions and compulsions were time-consuming and would cause clinical distress and impairment in functioning in Shane. And the symptoms are not attributable medical condition and is not better explained by another mental disorder. Hence, for this case, OCD was ruled in. Shane also presented with major depressive disorder, and the prevalence of depression in adolescents can be as high as 4 to 8%. And it is more common 2 to 3 times in female than in males. And in children with a family history of MDD, the relative risk confers a risk of developing the disorder by 3 times more. As we recall from the history, Jane had an uncle who had depressive symptoms. Shane had the following depressive symptoms that comply with the DSM-5 criteria: depressed mood, marked diminished interest, decrease in appetite and sleep, a loss of energy, feelings of worthlessness and inappropriate guilt, decreased concentration, passive suicidal ideation, significant distress and impairment in school functioning, which cannot be otherwise attributable to substance and medical condition and not better explained by another mental disorder. So in this case, I wrote this in. I also consider the obsessive compulsive personality disorder as because, as mentioned in the premorbid, she already had this attitude of making sure things would be perfect. So OCPD is a comorbid in OCD in 23 to 32% of cases, and OCPD is also prevalent in the population for as high as 2.1 to 7.9%. However, personality disorders are diagnosed when the symptoms are pervasive and are usually diagnosed when the individual is at least 18 years old. So for this patient, she was 15 years old. So OCPD per DSM-5 is characterized by the following criteria. However, in relation to this case, OCPD is not characterized by the presence of obsessions and compulsions. And moreover, Shane does not hoard. And although she is devoted to productivity, she also tends to spend time for leisure and activities with her friends. And she is also not reported to be frugal or stubborn and is able to delegate tasks to her classmates as well. Hence, in this case, I ruled it out for now, but I plan to monitor it in this patient. So for my impression, this would be obsessive compulsive disorder with fair insight and major depressive disorder, single episode, severe. Questions po?
Okay, Nuev, although na-mention mo naman talaga no yung have OCPD as na-rule out mo, but considering her premorbid, do you think she has traits of
Yes,
OCPD?
yes, Doc. I should have included that, Doc.
Oo, no? That should be also in the diagnosis kasi it will help you, no?
Yes, Doc. I think that's enough po, Doc. Yeah, I missed that, Doc, to include it. There was also a paragraph in the SM5 po, Doc, na although we don't really diagnose it before 18 years old, we can already consider it for patients below 18 years old, especially if the symptoms are already prevalent for more than 1 year.
Oo, very pervasive kasi sa personality niya, di ba?
Yes, madam.
Even before the 36 months, no? Everyone knows her as that person
Yes,
who
doc.
is overly perfectionist, checks and rechecks her things. No, so yeah, kumbaga if we have to be very just by the book of DSM-5,
Yes, doc.
hindi natin i-diagnose, but we can see the distress and dysfunction related to those traits no? So include mo pa rin siya.
Yes, doc. I missed that, doc. I should have
Okay.
PD traits.
Question.
Yes, madam.
Can OCPD progress to OCD?
They do have different criteria po, doc, but they can, they can coexist as comorbids po, doc, as high as 23 to 32% po, doc, according to journals po, doc.
Thank you.
Thank you, doc.
How is she in school and how does she relate to her classmates?
In school po, doc, she's very, po, doc, socially, she really has a few friends lang po, doc. Dalawa lang, doc, ang close friends niya, doc. She, as mentioned po, doc, before, doc, she had this episode po, doc, na she was bullied, and in her own words na she was betrayed by her friends po, doc. So she tended to withdrew from her classmates po, doc, and really kept few close friends lang dito. In terms of po, doc, yes, thank you po, doc, for that question also. Since she was also the leader of their class po, doc, The grandmother also mentioned na she was bullied before. One of those contents po doc was she was very strict po doc as a class leader in terms of her classmates po doc. She was strict as a class leader. So mag-add po sa OCPD na ano niyo, traits po.
How about delegating works?
She was able to delegate work man po doc. But she's just so strict doc na if she delegate this work, she would expect it na mahatag doc ba sang i-delegate niya doc.
You mentioned she's friendly or not aloof or more of an introvert.
More on an introvert po doc. According to the grandmother doc, prior to the bullying incident doc, she was more friendly talaga doc. But after the bullying event, she really withdrew from her classmates.
Is there an element of trauma here after the bullying?
She did not mention doc na ano, laman siya nightmares ato doc or hypervigilance, or I think ang reaction niya more to that doc is kanang she felt bad towards them and she felt betrayed, but not of a more traumatic na reaction po.
Yeah, because since it happened, no, diba, she changed. So maybe you can explore that.
Yes, doc. Yep. So moving on with the biopsychosocial profile. So Shane was biologically predisposed to develop OCD and MBD due to the strong history of psychiatric illnesses in the family. So studies show that there are overlaps in the genetic loci between OCD and depression, schizophrenia, as well as generalized anxiety disorder, as seen in these journals. So Shane grew up in a negative family environment with an abandoning father and neglectful mother, to which Shane had feelings of anger or being unloved and feeling inadequate. And she also developed the inability to trust people because of this. So also studies show in the environmental factors, studies show that remote online modular learning also confers a risk. In a study by Rao in 2021 and Pasco in 2020, they showed that remote learning can cause social isolation, loss of social structure leading to mental health degradation. And 81%, as high as 81% of high schoolers are actually stressed. With increased academic related stress, there's an increased rate of depression, anxiety in children and adolescents. So both OCD and MBD are biologically explained by hypofunction of the serotonin system, and OCD by a hyperactive striatothalamo-cortical circuit, which I will be explaining later on, which still involves a decreased serotonergic function. For the social and psychological, because Shane's mother chose to stay in Manila. This caused resentment and anger in Shane towards her mother. I will further elucidate this in the psychodynamics. And these feelings in Shane elicits defense mechanisms that may lead to the OCD symptoms and depression. So furthermore, Shane also felt inadequate and unloved and felt herself as a failure. So perpetuating factors in this case are the comorbid MDD, which confers low energy and decreased concentration and motivation in Shane. So also the continued hypofunction of the serotonin system and hyperactivity of the CST C circuits also perpetuated the illness. The piling in her modules in school, the strict deadlines, family members at home telling her it is her fault, resulted in delays in seeking treatments. And while Shane also take this as a validation and believes that this and blames herself for her failures. So protective factors are Shane's insight and willingness to be treated, the support of her family and teachers, and access to IPBM services. So we are presented with Shane, a 15-year-old female who came in due to declining school performance. So Shane had a difficult childhood, and she was unplanned and unwanted. And she was conceived and was left by her father at an early age. Her mother, on the other hand, is distant and uncaring. So Shane felt neglect and abandonment from both her parents. But she felt it more with her mother when recently she chose to stay with her recent partner. The only person that she was able to turn to in the past, her grandmother, have also recently been unavailable due to the death of her uncle. Freud posits that in OCD, there is regression to the anal stage of a psychosocial development, which is marked by intensification of aggressive drives mixed with libidinal components in sadistic impulses. According to Freud, OCD arises when unacceptable wishes and impulses from the id are only partially repressed and so provoke anxiety. In this case, Shane had aggressive wishes towards her mother arising from the id, but is repressed by her superego. As a result of the conflict, the ego employed three defense mechanisms, eventually leading to the symptoms of OCD. The first defense is isolation, wherein Shane attempted to isolate herself or disown the undesirable thoughts and impulses. And when the forces of the id dominate, the impulses intrude rather as obsessional thoughts. The second defense is undoing. So when the isolation fails, the second defense would be undoing, which produces compulsive acts such as washing away unacceptable impulses and obsessive counterthinking and obsessive checking. The third defense is that of reaction formation, wherein Shane is taking on traits that are opposite the unacceptable impulses, such as compulsive acts, asking for forgiveness as a way of countering unacceptable aggressive impulses, giving rise to the OCD symptoms. So taking from the aggressive wishes from the id. So furthermore, Shane also developed depression. So according to Freud, depression is anger towards turned inwards in the form of self-reproach and self-attack. So this is considered to be an attempt by one's ego to spare a loved object from harm. In this case, it Shane's internal hostility towards her mother. So in the setting of the background of Shane's genetic predisposition, she developed depressive symptoms as well, which were concurrent with her OCD symptoms. Questions po and comments before I proceed to the course in the OPD po.
Later na yun sa akin.
Thank you.
Did you subject the patient for neuropsychological test?
I did po, Doc. Pero due to the pandemic po, Doc, na-move ang schedule niya. So, unfortunately, wala pa ko, I was really hoping also for the NPT, Doc, because especially with the history of schizophrenia in the family, it would really guide me also with the management, no? Maybe as I would later on discuss po.
Thank you.
Thank you po, Doc. These were my goals for Shane. So primarily for the goals would be the psychoeducation for both the patient, the family, and the teachers, as outlined, as well as school arrangement. Particularly also, I would like to assess the beliefs of both patients and caregiver with regards to the illness and enhance the family functioning in terms of destigmatization and improve support in terms of the grandmother, mother, and uncle. Ensure adherence to medications, laboratory testing, NPT, and as well as pharmacotherapy to control the symptoms. And these are my other long-term goals: to monitor for symptoms, ensure adherence to medication, and CPT. So I took this algorithm from the Journal of American Academy for Child and Adolescent Psychiatry. So as we can see, for moderate to severe symptoms, a combined treatment already with SSRIs and CBT is warranted. So this was the first, this was already discussed. So there are 3 FDA approved SSRIs for OCD in children, These are sertraline, fluvoxamine, and fluvoxetine. For MDD also, the APA had this cohorts in 2019, which showed that a combination of psychotherapy and pharmacotherapy for treatment of moderate to severe depression as well, and SSRIs as the first line of treatment. So they also identified the following SSRIs. So in this patient, I chose fluoxetine as it is indicated as the first line for both OCD and MDD with good response according to the RCTs. For in terms of efficacy, it is better compared to TCAs. However, there are no head-to-head studies that I can find comparing fluoxetine and other SSRIs. But in a meta-analysis done by JACAP in 2012, the absolute response rate, this is a 25% decrease in CY books scores after treatment between SSRIs. It can be 16% for sertraline and fluvoxamine, and it is higher in fluoxetine for 24%. However, the downside to fluoxetine would be it has less tolerable side effects compared to others, especially compared to sertraline. It can have more insomnia, nausea, agitation, tremor, and fatigue. However, in our institution, also fluoxetine is readily available. So her other uncles are also taking medications from IPBM. So I considered giving fluoxetine for this patient. Of particular note, however, as with all antidepressants used in adolescents in particular, we should be closely monitoring patients for suicidal ideation or behavior. For treatment, it may take 12 weeks for substantial benefits to occur, and treatment is generally continued for 6 to 12 months after stabilization, and then would be gradually withdrawn. So again, CBT sessions would really be helpful in these cases to address recurrence of symptoms. So a follow-up was requested a week after so that I would be able to check on the lab results and to monitor for side effects and tolerability of the medication in Shane. As can be expected, there were no really improvements yet in the first week. However, in this time, I really attempted to contact the grandmother. However, she was not home at that time, so the mother was also otherwise occupied. So I just kind of enhance more on the psychoeducation sa uncle who was present with the patient. So at this time also, I was able to talk to the patient's advisor and was able to explain the situation as well. And they were more than willing to accommodate the patient in terms of the situation and give more leeway in terms of the deadlines. So on follow-up, the lab results were also normal, and there were
Just a,
no
just a clarification regarding talking to the advisor. Paano mo siya na-bring up sa patient? And was she okay with it?
yes po, Doc. Both of the patient and the uncle were really hoping, Doc, na she could rest for a while, Doc, sa school. So I offered na lang, Doc, na that I can explain to the advisor the
Okay.
situation so that she can be given some time po, Doc. They were able to give her 2 weeks nga rest po, Doc, and they really moved the deadlines to a month po, Doc.
Okay. How about also yung na-inform mo or na-educate mo sa advisor regarding the confidentiality?
Yes po, Doc.
Wow.
I ask permission po, Doc, sa patient po, Doc, and siya po mismo, Doc, she really wants me nga ako po lang mag-talk sa advisor, Doc.
Okay, that's good. But what I meant was like with regards to the
Ah,
information that you got,
ah,
aware ba si teacher sino yung mga pwede niyang i-inform regarding that?
ah,
Etc.
we discuss it together po, Doc, with Shane. So para dili po maano na the advisor was able to ano po, Doc, discuss this also with the principal po. Kanang sa ilaha lang po, Doc, nga features, Doc.
Okay, thank you.
Okay po, Doc. So these were the lab results, and they were normal as well. So again, I requested for NPT, but however, this was moved due to the pandemic. So in the next follow up at this time, I was able to contact the grandmother and the mother through phone only. The grandmother, however, was really still distressed about the passing of her son, and she was crying all the time during the phone call. And so I just offered supportive psychotherapy, and I also advised her to seek consult as well. I think this is important because the patient was really identified her grandmother as her primary support. So I think enhancing also the addressing the problems of the grandmother would also address um, the problems with our patient as well. So also I was able to reach the mother at this time, and I was able to elicit the views on the illness, and psychoeducation was done. At this time, the patient had improved mood, however, was still worried over her subjects. She was able to plot a schedule to comply with her deadlines. And, fortunately, she was allowed to do her homeworks typewritten, so she would not have to rewrite and rewrite. And she also noted that she still had problems with concentration and intrusive thoughts. Um, So during the next follow-up, the grandmother mentioned improved mood already, and she would play with her cousins, and she no longer cries. She also mentioned that there was a lessened severity of intrusive thoughts and was able to slowly work on her modules. The patient and he also discussed, by this time I was able to have a supervision, and uh, I also tackled on the advice on managing ang accommodation of the family towards the patient's compulsions po, Doc. So I advise them that the accommodation would exacerbate the symptoms of OCD, and advise them about the cycle in OCD. So while I advise them to validate the patient's feelings about the patient's symptoms, uh, they they have to be aware that accommodating would make her exacerbate and symptoms, and they advise to express also confidence in the patient that she would be able to tolerate the anxiety, and define their new role in the patient of not tolerating her compulsions already. So we discussed so after that we discussed also with the uncle how he would be able to externally control compulsions of the patient, especially in terms of the assignments. She would reread and redo her assignment, so she would work on her modules from on a limited time, and she would pass them to her uncle to avoid reviewing, rechecking, and that her uncle already passed to her advisor. So she also say yaling suggestions, would just start with the easy ones and would pass them within the allotted time. So at this time, I just maintained fluoxetine at 20 milligrams. So in the next follow-up, a Zoom meeting was done with the patient, grandmother, mother, and teacher, her advisor, to assess the progress of the patient. Although the patient was able to finish her modules, she admits that she still had intrusive thoughts, but with lessened compulsions. For accounts of the grandmother, the rechecking or reviewing was already lessened at the time. At this point, however, since there's still intrusive thoughts, I plan to increase the fluoxetine to 40 milligrams. In per guidelines, actually, the fluoxetine should be 40 to 60 milligrams for OCD. In retrospect, I think it was a lapse in my judgment that I could have increased the dose already at this point. At the time, however, I think I was being wary of the effects and tolerability with higher dosing. I also scheduled the follow-up the next week after. So I was planning to re-administer the CY box. However, the patient was not feeling well at the time, and so I was not able to do the follow-up. So I was we were able to do the follow-up already February 10. So I re-administered CY box at this time with a score of 23. So according to journals, the target reduction would be at least 35%. So this was less than 35%. So mood was apparently improved, but since OCD is still not addressed, I increased the fluoxetine to 2 times a day post meal, so that would be 40 milligram once a day. So I emphasized to the patient that the effects of the pharmacotherapy could actually would take long, and that as well as conferring hope to the patient that letting her see that there's still there was improvement, no, and with adjustment in her medications, we can still see more improvement. So patient is due for follow-up within this week, and plan to duly assess her progress as well, and also to follow up on her neuropsychological test. It has come up with one of our in our supervisions, they about the adjunct antipsychotic. So um, in algorithms, we can do adjunct antipsychotic if it's resistant or less than the targeted response of more than 35%. But at the same time, I was also considering the possibility of doing the adjunct if depends sa NPT if I can simbasig na yung mga psychotic tendencies ba doon. So that's one thing I still have to do po. Questions po?
None for me.
Thank you po. So, this is my final impression. To add to this, the OCPD traits po. So, moving on to the discussion, which is the neurobiological psychopathology of OCD and its link to MDD. So, in patients diagnosed with OCD, 20 to 62% actually would have depression. While in patients with MDD, they may have 22 to 38% with 38% with obsessive compulsive symptoms. So there are cross-sectional twin studies which indicate that there are common genetic factors that can explain 52 to 65% of the phenotypic correlation between OCS and depressive symptoms. So this was according to Bulwis in 2014. So I come across studies. This would seem too reductionist, no, to limit it to this kind of discussion. But since my objective was to look for the link, no, I, I, I tended to go through this specific link. So since, as we mentioned, no, OCD and MDD would come from hypofunction of the serotonergic system. So in both studies by Honda in 2017 and Fratelli in 2020, they looked into the promoter region polymorphism, particularly the 5-HTT-LPR, which is part of the SLC6A4 gene, no, that are seen across patients with OCD and MDD. So actually, this gene is responsible for the serotonin receptor in the presynaptic neuron that can cause the hypofunction of the serotonergic system in both cases, no, of OCD and MDD. So what happens in OCD is that with decreased serotonin, it has interplay also with dopamine and GABA, but eventually it would cause the overactivity of the direct pathway more than the indirect pathway in the corticostriatal thalamus cortex loop, no, which would cause the symptoms. No? So this is just a simplified view, no? So for in the orbitofrontal cortex, no? So in the OCD brain, it would detect an error when there isn't actually one and would send worry signals. So in the basal ganglia, this would be responsible for the reflexive and repetitive behavior. And in the cingulate gyrus, the brain would add emotions like disgust, guilt, and anxious thoughts. And for the caudate nucleus, the OCD brain would fail to filter anxious thoughts. So again, no, to go into the link of OCD and NDD, again, it's a decrease in the serotonergic or the hypofunction of the serotonergic system. So in SPECT scans, actually, they also see hyperactivity of the cingulate gyrus in some cases in both OCD and MDD, which would in one study which would actually predict their response to administration of serotonin reuptake inhibitors. So actually, the SSRIs would increase the neurotransmission, improve the serotonergic function. So as again, I mentioned it was too reductionist, no, this discussion that I did now. So we also have to consider other factors as well, no, other neurotransmitters such as dopamine and GABA. So, but when it comes to in simple terms, no, it's the hypofunction of the serotonin system as governed by the genetic factors that I mentioned. Um, so, to end this, the case presentation, I'd like to leave everyone with the saying that with ordinary talent and extraordinary perseverance, all things are attainable. So, this ends my presentation po.
Thank you, Web. Before we end, do we have any comments from the consultants or questions?
A comment lang, Web, since you discussed the neuroanatomy of OCD, it is parang important to mention the pertinent negatives test in your neuro exam in that particular areas. Yun lang.
Yes, Doc. Yes, Doc. Thank you, Doc. Well noted po.
Anything else? Okay, if there are none, thank you so much, Dr. Nueva. I would like to congratulate you for a comprehensive report, no, despite quarantine. You actually, I do appreciate how comprehensive your report was, and continue to have this supervised, no. I can see the supervision done with this patient, no. It I can also, kumbaga, we can appreciate how much thought with regards to management you put into this patient, kasi nga, yeah, at her age and her functionality, sayang kung hindi natin ma-address. Kailan ang next check-up niya?
Actually, Doc, schedule siya tomorrow po, Doc.
Okay, sige. So at least we can take into consideration yung mga na-mention namin para help mo pa yung patient more, okay?
Yes, pa, Doc.
Thank you
po.
so much.
Thank you very much po, Doc. Doc, mag-picture lang tayo.
Okay, sige.
Requesting everyone lang po, Doc, to
For the consultants pala, don't forget po to fill up the evaluation form that I already sent to you.
Okay, so there are 2 panels lang po, Doc. So 1, 2, 3. Next. Okay. Thank you, Doc. Thank you very much po.
Congratulations, Noel.